Hi, this is Dr. Mark Poole, and I'm talking now about acute and chronic viral hepatitis. Let's just review the term hepatitis. It's a general term that describes histopathological patterns of hepatocellular injury due to and associated with inflammation. This talk is going to focus on hepatotropic viruses and other viruses, but keep in mind that these changes are not specific to viruses or viral hepatitis and can be seen with hepatitis that's due to autoimmunity or that is drug-induced or toxin-induced. So we will just apply these same histopathological patterns in conjunction with other clinical and laboratory findings to establish a diagnosis. Now, viral hepatitis and all hepatitis can be divided into acute versus chronic forms, and this is based on clinical evidence of chronic disease as well as some subtle histopathological differences that I will review for this talk, as well as point out in a separate talk some features that are more typical for autoimmune hepatitis. Massive or confluent necrosis is not so subtle. It's pretty obvious. Most of the liver is dying, and that is a feature of acute hepatitis and acute liver failure, which we just talked about in the John Jackson case. This is a figure from Robbins that nicely summarizes some of the different histological features that are seen with acute versus chronic hepatitis. And so I'll try to show you some images that are specific examples for most of these things. Some of these things we've already talked about with the cirrhosis case in terms of portal fibrosis and bridging necrosis and fibrosis, but we'll go on from there. All right, this slide summarizes the main or key histological findings with acute hepatitis. And I'm not going to read them off to you, but we'll go through them one by one. In acute hepatitis, the main histological finding, and one that is nice in distinguishing it from chronic hepatitis, is the presence of lobular inflammation. And this means inflammation that is away from the portal areas in acinar zones 1 and 2, that is in the lobule itself. And usually this takes the form of a diffuse or kind of spotty involvement of the lobules. Now, as opposed to confluent or massive necrosis, which we'll get to, and which you've actually already seen with the discussion of acute liver failure, in acute hepatitis, at least in the beginning, one sees apoptosis or acidophilic bodies. And so this is an apoptotic hepatocyte. Remember from general pathology a couple months ago that apoptosis is a programmed type of cell death, and the cell condenses and shrinks, the nucleus becomes pycnotic, and eventually forms, well, we'll see next, an apoptotic body or acidophil body. When these areas become a little bit larger, you have lobular inflammation and focal areas of necrosis, which you may see referred to as spotty necrosis, and that's because on low magnification you see these spots or foci of necrosis that are scattered throughout the liver. This is just a higher magnification view showing the dropout of hepatocytes. These are normal or viable hepatocytes around the edges of the image, and in the center you see an absence of those cells, and what's left is this nuclear debris, necrotic cells, and a few inflammatory cells. At the edges of focal necrosis or lobular necrosis, you can see these dense eosinophilic or acidophilic bodies, and these are the apoptotic or acidophil bodies that are the end result of apoptosis. Perhaps this is a little bit out of order, but another feature of lobular hepatitis is hepatocellular swelling, also called ballooning degeneration. Now, if you remember from general apoptosis, the first step, which is a reversible step of cell injury, is that the cells and the organelles swell, and this is just a obvious manifestation of this, in which the hepatocyte swells, becomes balloon-like. Notice that the cytoplasm is cleared. If you compare the cell that is indicated by the pointer with hepatocytes that are viable and more normal appearing, where I'm pointing, you'll see how much larger this cell is. And so this is another feature that's seen with acute hepatitis. Another finding is bile stasis, and this is the collection of yellow-green material in expanded bile canaliculi and bile ductules. The area that I outlined with red is just lobular inflammation. If you follow that out, you can see it extending between and amongst cords of hepatocytes. Now finally, if the acute hepatitis is severe enough, you get areas of confluent necrosis, and this is what you've already seen before with acute liver failure. So there's nothing new with this, it's the same thing. So these foci, or spotty areas of necrosis, eventually coalesce into these larger confluent areas of necrosis, and again, what I'm pointing to are the necrotic areas, and then in between are these columns or cords of viable hepatocytes still hanging on by a thread. This is just a higher magnification view. Again, you can compare the viable hepatocytes around the edge of the image with these areas of necrosis in which there's loss of hepatocytes, these dense eosinophilic or acidophil bodies, nuclear debris, and some inflammatory cells. All right, let's talk some chronic hepatitis now. These are the features that you see with chronic hepatitis. Again, I won't read them to you, but we'll go through them one by one with some images. So the most important histopathological feature of chronic hepatitis is portal inflammation, or portal hepatitis. And this is shown in this image. The portal area I outlined with the triangle. The green arrows point to some bile ducts, just to show that this is a portal area. You'll see that there's, number one, it's expanded compared to the normal triad. And number two, there's too many cells in there. And what are these cells? These are lymphocytes and plasma cells. And so this is another portal area. It's again expanded. There actually is probably some fibrosis here as well, which is another feature we'll get to in a little bit. But I pointed to the bile duct just to show you the portal area. I circled some plasma cells and some lymphocytes, and you can compare those with some of the other cells in the background. So lymphoplasmacytic infiltrate in the portal area, classic for chronic hepatitis. Another feature is interface hepatitis, and this is describing inflammation that is adjacent to the portal area. That is, it's at the interface between the portal area or portal triad and the rest of the lobule. And so I encircled the portal area with the blue line, and then outlined the area of the interface, which again has inflammatory cells in it, and the red area. Another feature of chronic hepatitis is the formation of lymphoid aggregates, sometimes even with germinal center formation in portal areas. And so the BD and the red arrow points to a bile duct, so we can identify this as a portal area. This also shows a couple of the other features of chronic hepatitis, a pretty intense lymphoplasmacytic infiltrate in the portal area, and then the green area shows the interface hepatitis that's adjacent to the portal area and extending into the adjacent lobule. This image shows the lymphoid aggregate, and I'm pointing to the germinal center. As this process becomes more chronic, you get some of the features that we talked about a little bit with chronic liver disease and cirrhosis, and one is ductular reaction. And so the blue arrows and the circle point to these numerous small bile ductules that you see with chronic hepatitis, especially when you start getting the development of fibrosis in these portal areas as well. This is a low magnification showing a pretty expanded portal area. All of the pink strands of material is collagen that's developed in this portal area, and then you can make out the numerous bile ducts or bile ductular reaction in this area of portal fibrosis, and I just pointed out a couple with the red arrows, but you can hopefully recognize them throughout the image here. There are a couple histopathological findings that you can help identify the etiology of the hepatitis. One is ground glass hepatocytes that can be seen in HBV hepatitis. Now, I encircled these cells. I think this is the best example of the ground glass hepatocytes. So the ground glass refers to, if you will, the if you're looking at the bottom of a pop bottle, for example, where the glass is kind of thin in the middle and then thicker at the edges. But basically these cells have a large amount of eosinophilic cytoplasm that has kind of a homogeneous glassy appearance, and the nucleus is pushed out to the edge. If you looked at these under electron microscopy, the cytoplasm would be filled with the HBV virions. Another histologic finding that is seen with HCV hepatitis is the concurrence of features of chronic hepatitis. In this case, I identified the portal hepatitis. There's some also interface hepatitis as well. But the key thing is that there's also steatosis, and I outlined that in the red oval there. It has a macrovesicular and microvesicular appearance, if you remember that from before. And remember that HCV is somewhat unique in that it's associated with metabolic syndrome. Now we'll be talking a little bit more about metabolic syndrome and non-alcoholic steatohepatitis in one of the upcoming cases. So we'll put that more together later. But for right now, just remember the concurrence of chronic hepatitis plus steatosis. Be thinking about HCV hepatitis. So let's review some of the histopathological keys for hepatitis. We're distinguishing on clinical grounds between acute and chronic hepatitis, and then there's histopathological features that go along with acute and chronic patterns. Remember that lymphocytes and plasma cells are the predominant inflammatory cells for both acute and chronic hepatitis. So for acute hepatitis, we see inflammation that's predominantly localized to the lobule. It's associated with some features of hepatocellular injury, including hepatocellular swelling or ballooning degeneration, acidophil or apoptotic bodies. You get lobular necrosis, also known as spotty necrosis. You can see biostasis or cholestasis. And then finally, in severe cases, confluent or massive necrosis, which you've already learned about with acute liver failure. With chronic hepatitis, the inflammation is focused on the portal areas, and this includes interface hepatitis, which is the border between the portal areas and the rest of the lobule. You can get the development of lymphoid aggregates in portal areas. With advanced chronicity, you can get ductular reaction and fibrosis, which begins in the portal areas and then extends as bridges to other portal areas or to the central vein, eventually forming nodules and cirrhosis. There's a couple of features that are more typical for HBV and HCV, respectively. Ground glass hepatocytes are associated with HBV infection, and steatosis is associated with HCV infection. So I hope that helps going through these images, and happy hepatitis. Bye.